Welcome to this episode of Dental IQ. I'm your host, Fabio Alfieri, and this week I sat down with Professor Laurent Bozec, a highly accomplished research scientist and educator who's devoted a lot of his career to advancing the future of dentistry. Professor Bozec has recently published a paper outlining some of the potential negative effects of teeth whitening. We discuss what he found in his study and also what he thinks we could change in the world of oral cosmetics to preserve the health of millions of smiles globally. Stay tuned to hear from Professor Bozec and find out what he's discovered in this study about teeth whitening. Dr. Laurent Bozec, thank you very much for joining us on Dental IQ today.
Well, thank you for having me, and I'm delighted to be able to come and speak to you guys today.
Yeah, I'm very excited. And sitting in front of me, I've got one of your most recent reports that I'm very excited to actually dig deeper with yourself on. It's the compromised dental cells viability following teeth whitening exposure. I've had the chance to read this and it's unbelievably interesting. And I know that all of our listeners are keen to hear more as well about the research topic and the results. But let's start sort of more at the beginning, a little bit about yourself, Laurent. I'd like to know a bit about how you've sort of ended up in the industry that you're in currently and kind of what led to this research that you're doing. So where did you grow up and where was your education based?
Yeah, so thank you. So I grew up in France many years ago, and I was fortunate before the Brexit happened, some French students could move over to Britain in the UK to do their undergrad studies, and so I did. And then I loved so much universities, I decided to stay in university, and I was very fortunate to start a PhD very early on in my life. But because the topics of this podcast is about dentistry, I'm a physicist, so I'm a bit of a misnomer in dentistry because I come from a physics background, but I've devoted the last 15 years of my life to try to understand what I know about physics and biophysics to dentistry. So my background is straight physics, applied physics, imaging, which is something great because we can apply that every day into dentistry and dental science.
So you're saying your background started in physics. Where was that pivot from physics to dentistry? What caused that change?
So at the end of my PhD, where I was building equipment, I was doing a PhD in instrumentation, developing tools such as atomic force microscopy. I decided that at the end of that PhD, I wanted to do some more applied science that could help humans, can about health, try to investigate diseases using those tools. And in fact, I did a big jump going from a physics department to a medicine department. So I decided to leave a little bit the world of straight physics and instrumentation and go to the world of medicine. And that's where I started to work at University College in London, which I've been for almost 18 years before I moved to Toronto. And there I started in the Faculty of Medicine as a simple postdoc. And in fact, it was amazing because the first 6 months of my job, my boss, Mike Horton at the time, the late Mike Horton, and I, we didn't understand each other. So he was a medic and I was a physicist. And we spoke different language. But what the amazing things was when we started to understand each other very well on a very deep scientific level, sparks started to happen because we came from completely two different backgrounds, two different way of thinking about the same problem. And in fact, it worked wonderfully well. So how's that pivot? Pivot is really about trying to want to change a little bit direction of careers and just trying to go something towards more health benefits. And how I came to dentistry afterwards is that it's interesting because during my postdoc and my with Mike Horton at UCL, I was starting to work on collagen.
Yeah, right.
And then sliding no moment at the end of my postdoc, I met with a Professor Robert Brown, that's departed also, but he just mentioned to me on a Wednesday afternoon, Laurent, you know, there's a job of assistant professor in that dental institute just attached to university. No, I didn't. The deadline for application is tomorrow. I submitted my application, got the job.
Wow.
And that's how you pivot from straight physics all the way to dentistry.
That's a big pivot too. You said something before about how your boss and yourself couldn't stand each other. Do you find that between the sort of physics world and the medical world, do you find the characters within those two worlds are very different?
people don't understand you, and at the same time, I recognize a moment when I don't understand them. And in fact, we have to be very, very humble in terms of how we are asked for explanation, and just make sure that we find a connection. What I found amazing still today, when I work with clinicians, they expose a problem, I expose my solution, or vice versa. It always click. And
Right.
that's for the last 15 years I've been working with clinicians, and it's always an amazing experience.
Right. So, how much time in between landing this head of the dentistry department job and founding the Eastman Center for Postgraduate Research? How much time was in between those two?
So when I was appointed assistant professor at the UCL Eastman Dental Institute, I've always been interested in trying to develop a young researcher. I think it's one of my mission, my career, is to work with very, very aspiring young PhD student, younger than me, and very, very, very clever people, much more clever than me, and try to make them go the extra mile and try to unlock the potential. It may sound very cheesy, but that's something I'm very, very passionate about. How you take a piece of coal and you shape it into a rough diamond, and then the diamond. In fact, before I become head of research, I took this position, exactly this position, about mentoring, about looking at the growth of the students. And it only when I became head of research that now I was in a position where I could try to create an entity to try to host all the PhD students under the same umbrella, with a vision again of trying to make them better students. We had about 80, it was oscillating between 80 to 100 PhD students. So at that institute, which is a huge, huge cohort of research students for Dental Institute. And since I've left, I believe it is still working accordingly to what I set out to be done in the first place.
With that many students, I mean, that research center would be producing such incredible work, I can imagine, and probably still is as well. So I know that your physics background, one of your largest areas of expertise is atomic force microscopy. Now, myself, I've got no idea what that is, so I want to hear a little bit more because I'm sure our listeners probably don't know too much about it as well.
So atomic force microscopy, it's a wonderful tool. So most of you may be aware of what's a microscope. It enables you to look through a set of binoculars at something that is very, very small, being the wing of a butterfly, or being just an ant, or which something that you cannot clearly see with just your normal eye. So unfortunately, because of law of physics, is this only some things that we can see with the eyes or with the best optics that you can have. And this is guided by the diffraction limit. So the diffraction limit is basically a law of physics that tells you under whatever light you can see the smallest object possible. Well, as physicists, we like to go as small as possible. And many of you must have seen images of an atom. Well, you can't see an atom with your naked eye. Actually, I rephrase that. You do see that every day because everything around us is made of atom. But in fact, if you want to isolate an atom, a molecule, a protein, for example, DNA, you cannot see it really with your naked eye. So what we do there, we use an atomic force microscope. And the easiest concept to understand that, if you got an old vinyl recorder and you put a stylus inside the groove of your vinyl record, the stylus go up and down based upon the little morphology, the little change inside that groove, and it produces a note of music. Well, atomic force microscopy is exactly the same principle. We use a very, very sharp needle, a stylus, to come into contact with the surface, and we measure the bumps and the groove on the surface, and then we reproduce the three-dimensional images of what the cantilever, that small needle felt on the surface. So it's a little bit like reading Braille, but at a very, very small scale. So in fact, when you see at that scale, you don't see, you feel.
Yeah, right. Correct me if I'm wrong. The atomic force microscopy was introduced because I think the original process was it scanning tunneling microscopy, if I'm
Correct.
correct.
So it was
Yeah.
a small evolution or big evolution of scanning tunneling microscopy, and in fact, Christoph Gerber and his supervisor. So the Nobel Prize was awarded for scanning tunneling microscope, and the atomic force microscope came along and make a big, big breakthrough with the first instrument only being commercialized in the late 1997, and it only made a breakthrough into science into the early 2000s. So it's not a terribly old technique.
Yeah, right. Because scanning tunneling microscopy could only view things that was conducting or semi-conducting.
So
Yeah.
that's correct.
Whereas AFM is everything essentially. So as you said,
Correct.
it's
So
like yeah,
yeah.
yeah,
So
it's like
with
but
AFM, we recently, for example, published some papers where we were looking at the property of ore biofilm. So that's our latest paper. We've looked also at how different materials that have got the consistency of the contact lenses, how we could measure the mechanics. We've been looking at different structure in bones. We've been imaging cells. And the beauty of AFM over other type of microscopy is that your sample or whatever you're imaging remains alive and remain into the correct condition, such as you can start really to study complex system and be able to make great science. So atomic force microscopy, yes, is definitely a tool to watch out and can be combined with other type of microscopy as well. So
right. So this is an area of expertise for yours whilst you were
yes.
sort of still working within the physics world. How have you adapted that since making the transition over into, the medical dentistry profession?
So I'll give you an example that's going to be very relevant to dentistry. So I was discussing with one of my very good friends, who's pediatric dentist, and she was telling me that she was trying to restore some teeth from children with osteogenesis imperfecta and dentinogenesis imperfecta, which is the conditions that affecting the structure of the dentine, the core part of the tooth, the bony part of the tooth. And in fact, it tends to be very difficult to restore, as in putting composite material and restoring them. And we started a project, and we published on this also, where we started to look at the quality of the collagen and inside the bone part of the tooth. So the dentine is a bit like a bone. It's made of a collagen component and it's made of a mineral components. They mash together and they form a nice structure with tubules, so long tubes that are propagating through the dentine. And what we found is that the collagen was abnormal inside the dentine, meaning that the composite material that is being used for restoration are trouble to bind very strongly onto the dentine material. So that was how we've been able to, for example, to look at the mechanical properties. So we use atomic force microscopy to try to look very carefully around those tubules that are being formed, the mechanical properties of the collagen. So as I mentioned, we've also done a lot of work in terms of assessing the properties and the imaging of our biofilm. For example, we had another piece of work that was contracted by a big pharma company who had a feeling that mouthwash were promoting the formation of our biofilm. Who would have thought so?
Wow.
We tend to brush our teeth. We use mouthwash to rinse our teeth, and effectively, we should have a very clean mouth afterwards. Well, that company had an inkling that, in fact, the mouthwash that we're producing was promoting the onset of a new biofilm growth. So what we did there is to, again, use a microscope and modify the tip of the needles that we use with a live bacteria and try to look how sticky it was to a dental surface. And what we found is that if we immerse that single bacterium into a mouthwash solution, yes, it was dead. That was true. It was dead, but it was become 100-fold more stickier.
Wow.
So
it was killing the bacteria,
it
but it
was
was making
killing
it adhere
bacteria,
to the yeah.
but in making adhering a lot more. You'd say, what's the problem with that? Well, the problem is that in this case, we use what we called first colonizer. So these are bacteria that come first onto the dental surface. Their role is just to prepare for the biofilm to grow. Whether survive or not doesn't matter. So in fact, what happened is that yes, those primary colonizer were dead, they become super sticky, but they still adhere even more onto the surface, such as all the remaining bacteria could pile on top of them and recreate even more easily an old biofilm. So this is how you can use AFM to try to answer this sort of problems.
What was it in the mouthwash that was causing this?
The mouthwash, the critical component of the mouthwash is chlorhexidine, which is an antimicrobial that is being used commonly into mouthwash, even into Band-Aid and so on. It's just it's a very, very common one.
Jeez. So this AFM, this atomic force microscopy, is this a process that you used in this recent study that you've published on the effects of carbamide peroxide?
We did a little bit on not on this particular study, but on the previous studies that preceded our recent finding, in which we were interested in looking at the structure of that collagen that sits inside the dentine when exposed to carbamide peroxide. Carbamide peroxide is one of the compounds that's being used into tooth whitening agent. In fact, that carbamide peroxide is the element here, the very important element is peroxide, because the carbamide peroxide can break down into hydrogen peroxide. So hydrogen peroxide is more well known as bleach. Okay, this is bleach. This is your asshole bleach that you can clean your bathroom with. That's the core element. So what we found is that we started to evaluate a little bit the impact of bleach onto collagen. The reason why we started to look at that is because our first study had nothing to do with tooth bleaching, but we were interested with root canal treatment. In root canal treatment, unfortunately for patients who have to undergo root canal treatment, the endodontists tend to use bleach to try to disinfect the inside of the canal to kill all the bacteria. And it's a very effective process. It's a process that's been known for several decades and is still very widely done across the world. So what we were concerned during that study is how the protein inside the dentine, so that bone part of the tooth, could be affected following exposure to root canal to bleach, root canal treatment to bleach. And what we found is that, in fact, yes, the collagen was being quite badly affected. And again, this has been published. We're now working on solutions to try to prevent this to occur. So when we looked at the composition of tooth whitening agent, we said, wow, hang on here, we've got a compound that can turn into bleach. So we found already that the damage could occur inside the root canal. Let's see what happens in the case when people are using tooth whitening at home. And we were partly concerned with individuals that keep on reusing over and over and over tooth whitening agent, and just basically, so I'm talking here about gels that sit in tray, and you put those tray overnight inside your mouth for 8 hours sometime, and effectively you get up in the morning, you got beautiful, according to them, white smile. So we started to look at that, and we started to look at the structure of the collagen, and we started to see that the collagen was seriously disrupted. So using AFM, we are able to see the change in the structure of the collagen. So a collagen that is healthy at the scale of an AFM look like long spaghetti, but on this spaghetti, they've got an annular periodicity. So in fact, they're not very straight, but there's a little ridge along the fibril. Interestingly enough, that annular periodicity is conserved across all species. So if you take a bit of collagen from a cow, or from a shark, from any species who has collagen, you can see that banding periodicity along the fibril very, very, very obvious, and it is conserved. Now, what we started to see as soon as we exposed the collagen to bleach, effectively, is that banding periodicity disappeared and turned the collagen into gelatin. So it broke down the collagen. So that's how we used AFM to try to quantify some of the degradation of collagen
Right.
inside the enamel, inside the
as
dentine. Sorry.
And as you mentioned before, moving on to this study that has recently
Yep.
been published, it's looking at the use of at-home teeth whitening kits. And
Correct.
you said like a lot of people sleep with these teeth whitening kits in, but I believe this study was measuring 4-hour treatment as opposed to an 8-hour
Correct.
treatment. And
That
you've
is
also
correct.
you've got 15% and 16% carbamide peroxide formulations as well, right?
Yeah. So we went, in fact, for some of the tests, we went to 10, 16%, and some of the other tests we've been to an even broader range from 5 to 35%. So in our first studies that was published in 2019, we showed that the dentine was seriously affected through the perfusion of the byproduct of degradation of the carbamide peroxide. So the hydrogen peroxide, the bleach was penetrate very, very deep inside the dentine, probably through those tubules like I've mentioned before.
You said byproducts, Laurent. So just for anybody who might not understand, so the byproduct of carbamide peroxide is hydrogen peroxide during the whitening process.
Correct. Yes.
Yeah.
Yes.
Yeah.
But
Sorry.
hydrogen peroxide will now also react. So the whole point of the hydrogen peroxide is to generate a free radical that will also interact with a chromophore inside your teeth. So the whole point of this process is to break down the big molecules that sit inside your teeth, being the enamel, being the dentine, so that according to whoever uses this product shouldn't be there because they tend to taint or give a different color to the tooth as they wish that they don't wish to have.
Right. These
So,
free radicals that you mentioned, sorry, just quickly, the free radicals
yes,
you mentioned, it's most typically hydroxyl radical, but obviously depends on the oral environment based on
that
the
is
other
correct.
ones. Right.
Yes. Yep. So this big chromophore can be due to, for example, if you knock your teeth, if you knock one of your front incisors, for example, your tooth can darken extremely fast, and it looks almost black. In fact, what you have underneath the enamel there is blood. Or if you drink a lot of coffee, you can have a lot of tannin stain also on your teeth. So in fact, this big chromophore is there as a result of lifestyle. But for those who wish to whiten the teeth, they decide that it's actually not acceptable to have this chromophore in place, and so the chemistry is there to break down those big molecules, and they're being broken down through the hydrogen peroxide approach.
Right.
So we've shown that the dentine was affected very deep. So so in this new publication we wanted to showcase two pieces of work. One, wanted to understand how, if you put your carbamide peroxide into a gel, how can you access so easily the dentine? You still got an enamel layer. You still got the enamel layers that sit on top of your dentine. And the enamel is, I would say, almost 90% made of mineral, and it's a very, very well-ordered structure. And as a physicist, I tend to call it the shield of your teeth. So it's there to protect the softer dentine that sits below, and definitely the softer pulp or the vital element that sits at the core of your dentine. So what we did there, we tried to measure something called the ratio of the protein to mineral content. So the enamel is really a structure that is extremely regular with some small prisms that tend to repeat themselves. And in between each of these prisms, you've got some very, very well-defined little protein that sits there that almost acting as a sealer around this prism. So the prism are very rigid, very well defined, but unfortunately, as we use the peroxide-based tooth whitening, the protein around the prism tend to dissolve. And in fact, in our study,
so this protein is enamelin and so forth. That kind of creates that sheath around the teeth. Correct? Right.
Correct. Yes. And so we found that, in fact, using the stoof whitening agent, they tend to reduce by up to 50% the amount of protein that's present in between these enamel rod, meaning that now you're opening some very, very tiny gap in between those crystals for the peroxide to actually penetrate inside the inner part of the tooth.
Right. Okay.
So
So
this is very, very important.
It's increasing the permeability of the enamel by
Correct.
reducing that protein
Absolutely.
content. Okay, I'm with you.
Absolutely. So one thing, for example, we haven't looked at, in between the dentin and the enamel, you've got a very, very important protein layer that act as a shock absorber. So if you knock your teeth, you've got a shock absorber, which is called the enamel dentin junction. And this again is a protein layer that we haven't investigated. That's something that we would like to do in the future. What I was going to say, so once a peroxide penetrates and reach the dentin, then it can so we wanted to see what would happen to the cell that sits at the core of the dentin itself. So we decided to grow some human dental stem cells and try to see whether we could expose them through a dentin layer to the same component of a tooth whitening. So we created an in-house model, a perfusion model, and the dentin layer was 3 millimeters. So effectively, we had a tray at the bottom of the tray with our dental pulp cells that were separated to our carbamide peroxide, and the separation was made by a 3 millimeter dentin slab. So 3 millimeter dentin is absolutely gigantic when we look, for example, at incisors, where the thickness of dentin between what we call the pulp chamber and the enamel is just maybe about a millimeter. So we grossly overestimated that thickness, the thickness of the dentin layer, just to be sure that we're not trying to promote the effect. So the only way that the peroxide could leak out was through the dentin layer, through the dentin tubules. And as he was penetrating through the dentin tubule, underneath it, what we had was a layer of dental pulp cells. So what was very, very interesting is that as a function of the concentration of carbamide peroxide, we were able to measure a significant reduction in cell viability. So what does that mean? Effectively, cells were dying very fast. They were dying very fast. In fact, what we found is that at 35% so carbamide peroxide gel, the cell were dead 99% within less than half an hour. So with it, for 10%, we found that it was almost also half an hour. At 5%, we found that it took a lot longer for the cell to die, but eventually they also die. On our control sample, the cell didn't die. So in fact, what we would so the only way that the cells could have died is by being exposed to the peroxide coming from the carbamide peroxide.
Right. I have a question on that point as well, because I want to know from your point of view, Dr. Laurent, is how applicable is this in an in vivo environment? Because, there's obviously a lot of factors, like pulp pressure, for example, that would contribute to, mitigating the effects of this cell damage and cell death. So from your point of view, how, viable is it in an in vivo situation? In vivo being sort of obviously in the mouth, like real instance. Yeah.
So it is true that a lot of comments that were originally on our review of our studies was there is partial pulp pressure that will make sure that fluid does not penetrate all the way down into the pulp. That is true, but in our case, all the dentin tubule were also filled up to halfway with growth media. So in fact, we had also a partial pressure inside our system, and still, as soon as the peroxide managed to come into contact with a growth media in which the cells were being cultured in, they still managed to diffuse all the way down to the base of the plate. So that was one of the issue. But the second issue, and we acknowledge into our study, so we didn't take into account the innate defense mechanism. So as soon as cells will start to detect peroxides, they will normally try to create a defense mechanism to try to protect themselves. And we didn't take that into account. That's why we are only, it's only an in vitro model, but it is an important in vitro model because to our knowledge, this approach has never been demonstrated. Nobody has ever thought that the use of tooth whitening overnight trace may eventually induce cell death.
For sure. And I suppose there's certain aspects of the study that kind of reinforce that as well. For example, the 3mm dentin disc, as opposed to the typical 1mm that you'd find in your dentin. And also the fact that it's a 4-hour treatment, not an 8-hour treatment, which some carbamide peroxide uses are overnight as well.
Yep.
So there are certain things that, although it might not be a direct essentially set of proof to say that in vivo here are the results, but it's essentially saying like this is the possibility of what's happening when you do use carbamide peroxide in vivo.
So in fact, having looked at tooth whitening for quite a while now, one of the main issue about tooth whitening is hypersensitivity, and the patient or the individual feeling sore teeth after having whitened the teeth. So if we think about what's lying inside the dentin tubule, we've got nerve cells, we've got a lot of different odontoblasts, we've got a lot of different cells. And in fact, so the cells that we use lie very, very deep inside the pulp chamber. So it's really at the base of the tooth, at the tooth, yes. And so they're unlikely to be directly exposed to that to the peroxide. However, the whole raft of cells that sits on the periphery is that likely to do. And if, for example, nerve cells start to be exposed to peroxide, that is certainly going to give an hypersensitivity response. So in fact, one of the arguments related to tooth whitening has always been about the change in pressure inside those dentin tubule. We may want to review this and saying it might be an overexcitation of the nerve cells inside the tooth being exposed directly to the peroxide.
Right. There's a really interesting point in here, which you touched on before. It says that 5% carbamide peroxide and 10% carbamide peroxide display similar results, similar whitening results, I believe, but with the 5% carbamide peroxide, significantly less cell death than the 10%.
Yeah, so the notion of 5% carbamide peroxide is, so it's always, based on our study and our finding, we would always advocate for the smaller concentration of carbamide peroxide as much as possible. 10% we can see that is almost reaching the same killing rate as a 35, so it's almost that we reach already an oversaturation of peroxide, and it tends to kill the cells as quickly as 35. So this 5% doesn't go as fast. So in fact, but in terms of improvement in whitening, there is debate whether the 5% is providing as much whitening as individual would want. And in fact, it's my approach is for those who want to whiten their teeth is to go slow and go steady and just making sure that you understand what you're doing. I think the faster it goes, and that the faster you want the process to occur, the stronger the concentration you're going to use or different modality, but there's also risk associated. But I wanted to come back on the in vivo component that you mentioned. So how could you translate that in vivo? So to date, I'm not aware of any cases of dentists that have any case of dentists that reported a clinical case where, for example, a tooth fracture has occurred into the patient as a result of tooth whitening or other adverse events. The reason why is because I don't think dentists are looking for that. They're not looking. So a tooth fracture would occur. The last thing they probably would be looking is about as a patient has over-whitening the teeth, for example. So why is it partly important? So why do I link to fracture and teeth? Is that in the case of the dentine, so that bone component in the middle of the tooth that provide all the support for the tooth and the growth of the tooth, if the collagen is being completely removed and the cells are being damaged, first, we have to know that teeth do not regrow. They can adapt to a bit of damage, but they do not regrow. So this is completely misnomer. So they do not regrow. So if the collagen is degraded, the cells are harmed. So now your dentine turned into a lump of stone. It turned into a lump of mineral. So you lost all the elastic component holding the dentine together. Any kind of fracture will break down your tooth very, very fast. So I think that's something very important. Now, also repeating that experiment in vivo, for example, on animal model, well, in terms of an ethics point of view, knowing that we're going to be purposely harming an animal to try to kill the inside of the pulp, I think doesn't sit very well with me.
Of course. Yeah, so realistically, there is no way to conduct this study in vivo in a person without causing severe damage, because it would involve you drilling into the tooth and so forth, right?
In person, I would say no. In animal, it depends on where
The
people
ethics.
stand on ethics.
Yeah, of course. Yeah. So, I mean, that's why this study was so interesting to me, is because you've almost recreated as closely as possible the in vivo situation in vitro, and produced results that are, as accurate as possible, whilst also considering things like, again, the thickness of the enamel disc and the pulp pressure and so forth. So it is a very interesting read. The question I've got for you is, from your expertise, what do you think the future development of safe teeth whitening looks like then? Do you have a stance or an opinion on what that development and research might be?
For me, the safe tooth whitening involve a greater awareness by those who undertake these procedures about what the potential risk that involve. I think today it's okay. You go and either have your teeth white and you do it at home. You can. So the only thing you're being told is that you may see a bit of discoloration of your gum, or you can have a hypersensitivity. There's no long-term risk, and I think that's in a profession. Some things need to be looked at. Whether this long-term risk are evident. So another aspect is that, so at the moment, all tooth whitening approaches want to go as deep as fast as possible. So it's a different whitening product, and it'll be interesting to see how far down inside the tooth do we need to propagate those different compounds to provide a change in color. We do not need to go very deep inside the tooth. We may not even need to go into the dentine, and we can remain inside the enamel. And unlike inside the dentine, the protein inside the enamel regenerates. So if we could confine the whitening within the enamel, I think that would be a great approach. And finally, I think it's important to try to see can we get away from peroxide agent? I mean, peroxide is everywhere in terms of from disinfection to changing your hair color to whitening the teeth. It is a very harsh chemical. And I think we owe it to the customer, to the client, to the patient, to try to make them understand what is the impact of using such procedures on themselves. For those who do it routinely, and this is a big thing. Those who do it very, very often, they're at much greater risks than they can even imagine.
One of my favorite lines from the study is actually in the conclusion, and it says that a compromise needs to be found between the concentration of peroxide used, the exposure time, the desired patient results, and also acceptance of the final adverse effects from the whitening treatment as well. And this is essentially a very scientific way of saying that beauty is pain, and you need to figure out how much pain you're ready to endure in order to accomplish how much beauty that you want to achieve from the result as well.
Absolutely. It's this procedure. So we're not talking here about in office. So going to see a dentist that prescribe you some tooth whitening because you're trying to correct some of the shade of your teeth. Here we're talking exclusively about those who do tooth whitening at home, and it's a self. I don't want to use the word self-inflicted, but it's a self-administered procedure.
Mm.
And what we have to be careful is that to say that it's all safe, because it's obviously not all safe, in the same ways that if somebody wanted to dye their hair with a peroxide-based product, they will know very quickly that they can't dye their hair every day, otherwise they're gonna be losing their hair very, very fast. Well, it is the same. It is the same concern, except there's never been a spotlight, and we always thought, well, the teeth is okay, it's very strong, it's very resistant. And in fact, it'll be interesting to see in about 20 years what would be the impact on our health, especially for those who have been over widening the teeth.
Mm. I'm sure, yeah.
But maybe to try to expand a little bit on this. So when I speak to my clinicians, they always ask me, but what's the alternative? What's the alternative to tooth whitening? Well, it's to file down the tooth and putting veneers. Because at the end of the day, the patient, the customer, will want to have a whitened teeth. So in fact, the dentists are stuck in that conundrum dilemmas a little bit. Do I put veneers, or do I let my patient whiten the teeth with a potential risk? And from a conservation dentistry point of view, you want to save as much of the tooth. So in fact, the last resort should really be filing the tooth and putting veneers.
Absolutely.
But it's a difficult question to answer.
Yeah, I mean, I'm sure I speak on behalf of a lot of dentists when I say that I think keeping as much of the natural tooth as possible for as long as possible is always the priority, isn't it? So I think you'd agree with this as well, where if you're going to be using peroxide, go and see a dental professional, because at least they can mitigate the potential risks and adverse effects, whereas at home you don't have the ability to do that. Whitening isn't for everyone either. So by seeing a dentist, they'll be able to tell you, hey, look, you are in a position where you can whiten, or you may have exposed dentin or, receding gums that might not qualify you for a whitening treatment. And knowing that information early can potentially save you thousands of dollars worth of treatment costs, let alone the access to a gum shield to prevent morphological changes to the soft tissue in your mouth, or, the over application of peroxide at high percentages, such as 35% hydrogen peroxide, which you can purchase online, which frankly is, a weapon to be used at home by yourself.
It is very scary, the amount of peroxide that's contained into the 35%. I often try to make a little bit the comparison with the bleach that we use in for cleaning bathroom and so on, and the 35% peroxide contain a lot more bleach than what we use to clean a bathroom. So as I said, for those listening, and just, would you put bathroom bleach inside your mouth and rinse it out and just make to have a whiter smile? Well, then think about whether you'd put 35% peroxide, because effectively you're going much higher dose than that.
That's an effective metaphor to use.
Yes.
I actually want to, on that point as well, I want to know your thoughts on the EU's regulation of the use of peroxide, because I believe it might have been in 2005 that they passed heavy regulations around the use of hydrogen peroxide in at-home whitening products to, I believe it's 0.1%, or if you were to go to a dentist, it's capped at 6%. In Australia, I believe we still offer 35%, and same with a lot of other countries as well. What are your thoughts on EU passing those strict regulations?
I think it's a good regulation, because the 35% should not make the place on the market. They shouldn't be on the market. It's like you said, it's almost a weapon. The adverse effect, yes, the results can be immediate. It's going to be absolutely immediate, but the patient or the customer will be suffering from very high level of hypersensitivity and the gum is going to be completely bleached and severely damaged. Actually, in part of our study, we looked also at cell line from the gums, and we saw also that there would be also significantly harm using those concentrations we just discussed. So I think any kind of safeguard is required. Just to try to prevent the customer and try to prevent to safeguard to protect the customer or the patient. Unfortunately, so whitening it's a difficult topic to discuss to dentists. The reason why is because there is an economic point of view of using and promoting whitening in dentistry. It's purely by choice. Most of the time is by choice of the patient or customer, and it's good economic for dentistry. Now with the access of those products online, you can still receive them through your post and just still carry on doing it. Doing at home, but I think it's there should be a health warning on this product to say this could seriously damage your house, and you need to be aware of that.
I think a warning is definitely necessary because I feel like a lot of consumers these days actually don't understand that your teeth don't have the ability to repair themselves like the rest of your body, and that's an important point to note because everybody has access to online shopping these days, especially in major markets. If you have the ability to purchase a 35% hydrogen peroxide kit from overseas, not having any indication as to what an unsafe percentage may look like and what a safe percentage may look like, you're completely in the dark about what's the best to be using for my teeth and what's the worst to be using for my teeth. And it's one thing that a dentist endorses whitening in clinic because, again, you can mitigate the risks and so forth, but consumers may think, you know what, I'm going to save a little bit of money, and instead of getting the whitening that my dentist endorsed, I'm going to order something online and I'm going to use it myself at home. And that's where the concern is, as you were saying before, and as what this study says here, that's where the serious damage begins to occur. And if you are constantly using a peroxide treatment at home that is far above what the safe legal limit is, pulp necrosis is a very real thing.
Right.
And that's something that is, again, irreversible.
Absolutely. In fact, following our first study published in 2019, our study was picked up by an online blogger, which I quickly corrected, but then we exchanged a few emails because we're saying, so what's the point of the study? Because the tooth is just made of bone and bone regenerate. So in fact, it doesn't matter whether we harm the bone part of the tooth because it will regenerate just like the rest of your skeleton. And also I did advise him that in fact this is absolutely wrong, and the dentin does not really completely renew itself. You may have a little bit of what we call secondary tertiary dentin that can be created as a function of trauma, but not to the extent of your tooth can be regrown from scratch entirely. Otherwise, why would we need denture?
Right.
We cannot regrow our own teeth, or adult teeth. So in fact, so I think this needs to. I would advise a health warning on this product saying, you got only one set of teeth, one set of adult teeth. Use it, lose them, but they're an asset. And in fact, if you mistreat them, you're gonna lose them forever. And then yes, you can have an implant, you can have a dentures, you can still have a functional mouth, but your original teeth are an asset.
Yeah. And look, personally, I'm more in favor of people finding a safe, responsible whitening method as opposed to opting for shaving all of their teeth down and receiving a full mouth of veneers. So if somebody is looking to make over their smile, talk to your dentist, find what the best solution is before opting in for a full set of veneers. But always having that consultation process so that you know that you are making the healthiest choice for your teeth, which is always going to be your dentist's priority as well. So yeah, always pushing people to have that conversation, which I'm sure based on this study is something that you would recommend as well.
Absolutely. Your dentists know better. The same when you go to your general practitioner, your doctor. If you got a headache or backache, ask what's going on with me, and you can refer it to a specialist. In term of whitening, yet your dentist know better. It's never been so interesting enough for me. This study, why we were so keen to publish it and to make it available as widely as possible. It's because as a scientist, as a physicist who has no take into dentistry per se, and definitely not into the whitening business, I was interested to see what was happening. I'm very surprised that there were no other studies that look at this potential side effect prior to our study. Interestingly enough, one of our peer reviewer, because this publication at peer review, is mentioned that it was a long time coming study. It said I've spoken to a number of dentists since the study has been published, and interestingly enough, they're all starting to come to me and say, you know what, I had some concern about tooth whitening. And it's interesting what you showed, because now I'm going to be prescribing less tooth whitening to my patient, or we're going to discuss a little bit. So in fact, the purpose of our study was not to harm the tooth whitening business, far from it. We wanted to create a discussion. Have a discussion with your dentist, as a discussion whether the procedures that you want to do it at home is safe. Do you need to do it as often as you do it? And just maybe speak to your dentist if you become addicted to such a whitening approach, and what could be the long-term effect of whitening your teeth on a regular basis, especially for those who are using a 35% peroxide. It's just is that 35 peroxide is a big issue.
Yeah, and that's absolutely right. And the discussion is the most important part. The discussion amongst consumers, discussion amongst dentists, even as well. So having people ask, why do I experience that sensitivity? Why is it necessary for me to have a gum shield? Why is this something that we have to accept in order to have this cosmetic benefit? And is it worth it for me? Is it worth it for my patient? Like, having that conversation is the most important part, as you said, and not just accepting that, this ingredient that's 150 years old, that all the books say is the best way to go, is my only option. So I think what the importance of these studies is kickstarting that conversation and having people asking the questions to themselves and also to their dentists as well about, what's my best course of action here, for sure.
And I guess another point I wanted to mention related to the study. So in our manuscript, we never shared the name of the supplier. The reason for that is because it's not a name and shame approach. We don't want to name and shame. And in fact, we've been working with supplier for a number of years. We've been working with that supplier for a number of years, and that supplier ended up creating a 5% concentration of carbamide peroxide based on the research that we've done.
That's amazing.
And yet the new publication came out and it showed adverse effect, and is still using the same original product that we use. So in fact, we've been working behind the scene with a manufacturer, but we agreed with scientific journals that we not name the manufacturer, because all what's important is the component, the chemistry, and the chemistry inside the carbamide peroxide gels that's being used, and the name of company does not matter. So in fact, we're not trying to create adverse publicity to that company, considering that they've been very focused on trying to create an ethical whitening approach using the carbamide peroxide.
Of course. I mean, two things on that. The first one, it's amazing that the manufacturer actually cares enough about, the people using their product, that they really wanted to make a change. Even if it affects their profit in the long term or whatever it may be, they are concerned about the health of the people using their product enough to make that change. So that's incredible. The second thing, as you said, it's the name and shame thing is, unfortunately, it is common in a lot of these studies. It's, I look at this company, look at what they're doing. And a lot of businesses struggle to recover from that sometimes, especially when it's, a scientific journal that is very hard to refute. So no, that's an excellent point. And I think it was a great decision leaving the name of the business out and mainly purely just focusing on the science behind this chemical and the oxidative process itself as well. Laurent, that's almost all we have time for. But at
Okay.
the end of every episode, we do a little segment called Quickfire Questions. I'm going to ask you 3 or 4 questions, and I'd love to hear the first answer off the top of your head. So let's dive straight in. The first question I've got for you is, did you have a role model in the early days of your career?
So I've been thinking a little bit about this. So role model for early days of my career. So as I said, I was a physicist and I came to work with a medic. And in fact, that medic was one of the first adopter of atomic force microscope to look at calcium signaling in a bone cell. And for me, the ways that it was in fact very interested with new toys. And in fact, when he passed away, I gave an obituarium and I gave a presentation as a symposium. And so his name is Professor Mike Horton, the late Professor Mike Horton from University College London. And he was my mentor. Is somebody that drove me, he developed me as a scientist that I'm today. And interestingly enough, he told me, Laurent, you should stop working on rat tail collagen because that's what we do in basic science. And you should go and work on rare disease related to collagen and what happened to collagen inside the body. And this study that we talked about it today started on collagen. It went on to cells and tooth whitening. But every day in my lab, we talk about collagen in various parts of the body. So yes, definitely the late Professor Mark Horton from UCL. Yes, that was my role model.
It's incredible to hear that you went from having a relationship as a boss and employee and hating each other to him being your role model.
No, it was not hating. We didn't understand each other. We didn't, so there was no hard feeling.
Yeah, gotcha.
There was some misunderstanding on the scientific level rather than personal level.
Yeah, right. Well, it's incredible nonetheless that he's become your role model. Yes. And I'm sure that the things that he's taught you, which you're now accomplishing, goes on to, change an industry forever. Like it's incredible to hear that. All right, question 2. Name one person in your industry whose work you currently admire.
Well, I'm going to go beyond my industry because I think it's the same sort of mind frame, but this time at a global scale. And in fact, for me as a technologist, looking up at being a physicist, developing equipment, instrument, trying to understand the next step and developing new technology. I'm going to be very biased. I'm going to say Elon Musk, because for me, having seen some of scientific presentation around Neuralink was doing with SpaceX, and I just wish it could apply some of his approaches to our health and having that complete futuristic or innovation associated to our industry. We need somebody like that to come and revolutionize how dentists fix teeth. And so for me, it's definitely somebody, I'd love to have a 5-minute chat with him.
Well, typically what we do is we take this snippet from the episode and we send it to the person to try and get them on the podcast. So if Elon Musk joins the podcast,
yeah. Absolutely.
I'll make sure
I'd love to speak to Elon Musk and to see what the next future of dentistry. Some of the procedures that we still use today haven't evolved over 100 years. Yeah, and we're still using them. So we definitely need to think about how to make dentistry evolve for 22nd century.
I'll email this to him and I'll be sure to CC him, Lauren. All right, well, question 3. If this wasn't your profession, and also including the physics background as well, what would you be doing instead?
I'll be designing landscape. I've got a passion for building gardens.
Something creative. That's definitely a step in the opposite direction. That's incredible.
Absolutely. So designing garden and woodworking, yes, absolutely. So I wouldn't be behind a computer all day long. I'll be in a workshop.
Is that something that you do in your free time at the moment?
Yeah, absolutely.
Yeah. That's good.
Absolutely.
That's good. Well, it's never too late. I mean, it could always be the next career step after research. Maybe something in retirement. All right, last question. For all of the young people finishing their degrees and coming into this industry, what is your most important piece of advice for them?
So never believe that you cannot achieve what you want to achieve. I mean, I was a straight physics student. I stopped studying biology when I was 14. And I went to work into a faculty of medicine. where the first day of the job, so Professor Horton told me, Ron, you know about atomic force microscopy? Yes. Well, I know about collagen. Go and do some work on collagen atomic force microscopy. I've never heard about that word before. And in fact, you learn. So just take the plunge, go for it. And if you really want it, you can get it. And don't let anybody think otherwise. It's very, very important to chase your dream and not stop along the way. Everybody got the potential, everybody got a different potential. It's just a matter of time when everybody can realize it.
Incredible advice from somebody who took such a massive pivot in their career to such a wildly different industry. So that's definitely important advice. And anyway, Dr. Laurent Bozec, thank you very much for joining us on Dental IQ today. This has been unbelievably informative for me. And your research paper is public access. It is open access. For all of our listeners who would like to read, it's called the Compromised Dental Cells Viability Following Teeth Whitening Exposure. I heavily recommend having a read. But yeah, thank you very much again, Laurent. We hopefully will have you again on soon to talk about your next paper that comes out.
Okay, thank you very much. Thank you for having me.
Thank you so much for joining us this week on Dental IQ. If you enjoyed the podcast, please follow us and leave a rating. And you can also find us on Instagram at dental_IQ. If you'd like to join us on Dental IQ or have any topics that you want us to cover, you can reach me at fabio@dentaliq.com.au. Thank you so much for joining us again. We hope to catch you next week.
Dental IQ is produced by Highsmile.